excited to have you. You know what? I'll as people trickle in, I'll get the program going. So, first of all, I want to thank everyone for taking their time tonight to join us at Zio Plus. We're excited to be able to host another one of our webinars, this time with Dr. Bilal Chughtai, who has spoken with us before. A couple of housekeeping items just because of the amount of people. You have all probably figured this out, but there's no audio or video for any of the participants. If you have any questions, feel free to write them here in the webinar chat or in the Q&A box. We will save them, and we have allotted about 15 to 20 minutes at the end of the talk for Q&A. After that, we will do our raffle, so please stick around for that. And finally, after that, if you would like, we'll do about a 5 minute just product review. If you're interested to hear some more about the products at Zio Plus, do hang around for that as well. So, without further ado, I'd like to introduce Dr. Bilal Chughtai. Dr. Chughtai is an associate professor of urology at Northwell Health and chief of urology at Scioset and Plainview Hospital. Dr. Chughtai specializes in voiding dysfunction, female urology, and neurourology. He is an active researcher, has published over 300 peer-reviewed articles, authored chapters and books, and has presented at numerous prestigious national meetings. I'm going to hand it over to you, Dr. Chughtai.
Well, Derek, thank you so much for the kind introduction, and thank you everyone for spending your evening with us. And this is a topic that I really am passionate about, and I'm really excited to talk about some of the solutions some of the solutions for it as well. All right. So this Derek already did a great introduction, so we're good there. These are my disclosures. All right. So for an agenda, we're going to cover a couple of different things. So first, we're going to talk about what's the definition prevalence of overactive bladder. How do you manage it? What's the first line treatments you can do? What are pharmacotherapy options as well, and what are third line options for it? I think there's certain populations where we really have to think about where overactive bladder can affect them quite a bit, and this is where men and women can get older, elderly population, also those with other comorbid conditions such as depression, and also how there is potentially a paradigm shift with one of the Zio Plus products, which is Fluence. All right. So what is overactive bladder? The definition of overactive bladder is urgency with or without urgency incontinence, usually associated with frequency and nocturia. And this is defined by the International Continence Society. So what are the key symptoms of overactive bladder? It's frequency. That means urinating more than 8 times a day in 24 hours. Urgency, the sudden, compelling desire to urinate that's hard to hold back. Urgency incontinence was the involuntary loss of urine preceded by this sense of urgency. And nocturia, getting up at night to urinate. So the thing about overactive bladder is that what makes it really a challenging condition is that many people have it, right? And they do not seek medical attention for it. They suffer in silence without realizing that treatments are available. A lot of patients that I see will tell me things like, oh, I thought it was a natural part of aging. Oh, I thought we start in diapers, we end in diapers. So as we can see here, like with the iceberg, there's a small amount of the suffering that we see, and there's this suffering that no one talks about because there's this taboos around it. The thing about overactive bladder also is that it affects many aspects of life. So first, psychological. We know that overactive bladder can impact depression, make patients more depressed and anxious as they're worried about their bladder. It can cause lack of motivation, making it hard to leave the house. When you're at work, I mean, if you're working in a place that has limited number of bathrooms, or someone's by the bathroom and they go, hey, you're going there pretty frequently, so it can affect productivity, it can affect economic burden. For a lot of patients, it can also cause social isolation because you're afraid of going to places where there's no easy access to the bathroom. Or, for example, going to the movie theater where you might be able to sit there for an hour, hour and a half to watch a movie. And some movies are far longer than that. So it can lead to anxiety, fatigue, social isolation. In addition to that, it affects your ability to do recreational activities such as sports or hobbies because of finding bathrooms nearby. Also, it can affect sexuality because you during sexual activity, you're worried about having a lower libido because you're always worried about the sensation of the bathroom, and sometimes sexual activity can trigger more urgency episodes. It can also affect daily life, such as household activities, hygiene, and sleep as well. So who's affected by overactive bladder? Nearly 1 in 4 people above the age of 60. About half of men and over half of women between ages 40 and 59 experience symptoms of urgency, frequency, and nocturia. And urge urinary incontinence and overactive bladder are the most common causes of leakage or incontinence in the elderly. It may be a marker for frailty, and it's also linked with cognitive impairment. So it's hard to say which one comes first, but the idea is like this is a treatment that does have treatment solutions, and it is linked with a lot of other conditions as well. So when you go see a doctor and talk about overactive bladder, there are a couple of things. One is that the doctor's going to assess recognizing the urinary symptoms. They'll ask questions about how often you urinate, frequency, how strong of an urge do you have to urinate, urgency, how many times do you get up at night. They're also going to look at how these symptoms are consistent with overactive bladder, the severity, and how much it affects the quality of your life. An important part of it is also a physical exam. It's natural for sometimes in men to do a digital rectal exam and frequently in women to do a pelvic exam. You want to rule out comorbid conditions such as vulvovaginal atrophy or vaginal dryness, or stress incontinence, leakage with cough, laugh, sneeze, or pelvic organ prolapse, where the organs can herniate into the vaginal area. You also want to look for other comorbid conditions that can also mimic or exacerbate this condition, such as diabetes, dementia, depression, prostate, bladder cancer, enlarged prostate. You want to know the list of medications because you'd be surprised the number of times I'll have patients come in and talk about how they've got really bad overactive bladder right after they take their morning medications, only to find out that they're on a diuretic. And it's the diuretic, and no one told them that the diuretic could cause urgency, frequency, and a lot of urine production immediately after taking it. It's also important to have a test like a urine analysis, and possibly even a urine culture. The reason being is you want to rule out blood in the urine because certain conditions like bladder cancer, kidney cancers can present with just blood in the urine. You want to rule out pyuria or white blood cells and get a urine culture to rule out infection. This allows you to assess for other conditions which can cause these urologic symptoms. For a lot of patients, it's not uncommon to ask for avoiding diary, which documents the number of urinary episodes, the number of leakage episodes, and fluid intake. And a lot of times we will use standardized questionnaires to assess how much it can affect the quality of your life. The reason why we use these questionnaires is that it's not like we're trying to give patients busy work, but really what we're trying to do is get a set of questions that have been validated that we ask after a few weeks to understand what the progression is. Are we getting things better? Are things getting worse? Are things about the same? And also asking about what truly bothers the patient. Like, is it the uncomfortable urge to urinate? Is it the sudden urge to urinate? Is it the loss of urine? Or is it getting up at night to urinate? And especially when we hone in on nighttime urination, we do know that nighttime urination is very frequently associated with daytime tiredness, fatigue, lack of productivity, and even all-cause mortality because when you get up at night, I mean, it's easy to fall and lead to fractures as well. So these conditions do have a lot of comorbid things that can occur with them. So all patients benefit from what we call first line therapy. So what are these? These are things like pelvic floor muscle exercises, or I'm sure you've heard of something called Kegel exercises. Sometimes things like physiotherapy, biofeedback, and bladder training can also help. Sometimes with patients, we start things like time voiding. So in other words, if you urinate every 2 hours, whether you feel like it or not, that'd be one way to reduce potential leakage episodes. Lifestyle changes. There's a big shift towards having a lot of fluid intake, which is appropriate for some patients. Like for example, patients that are on GLP-1s, things like Ozempic and Wegovy. Those medications actually decrease your thirst mechanism. So a lot of those patients are encouraged to drink more fluid. But when you drink more fluid, it could exacerbate overactive bladder. So sometimes it's a matter of finding the right balance of increasing the fluid intake or the times where increased fluid intake would be less disruptive to your lifestyle. So this is where dietary modification comes in and also weight control. We do know that with a larger waist circumference in both men and women, there are more bladder symptoms, more urgency, more frequency, more leakage. With any reduction of weight, you can reduce urgency and frequency as well. It's also important to educate our patients in terms of like setting realistic treatment goals. So in other words, if you're 70 years old, to have the expectation that you're going to urinate like the way you urinated when you're 20 years old, where you could hold it forever, right? No leakage, no issues, maybe somewhat unrealistic for certain populations. But setting these realistic goals is a way for us to move things in the right direction. So for a lot of my patients, I talk about a 50% improvement in symptom is the goal we're trying to reach. And we sort of start from there and see what we can achieve together. Also for older patients, you may want to consider toileting assistance. These are things like, bedside commodes or even condom catheters or the use of certain types of external devices in both men and women so that there's less chance of falls with getting up to go to the bathroom. And first line treatment can be combined with any other overactive bladder treatment and should be part of any treatment plan. So for a lot of my patients, I will end up giving handouts as a way of sort of implementing this and this way to remind patients at every step along the way to utilize these. Now, second line treatment, there's basically two big classes of treatments. There is the classic medications that we've used for a long time called anticholinergics. The way that these work is that they prevent the bladder from squeezing and they bind to a receptor called the M3, M4 receptor. So basically, the bladder can't squeeze as hard, therefore reducing leakage episodes. These receptors are located all over the body. And the problem with that is that because they're located all over the body, you get some side effects with anticholinergics. These include things like dry mouth, constipation, and there's also a link with dementia with anticholinergics. The other class of medications, beta 3s, they came out roughly in 2012. There's two players on the market. There's mirabegron and vibegron. Vibegron has come out more recently in the last couple of years, but basically what these do is tell the bladder hold more urine, right? They don't affect the contractility of the bladder. They allow the bladder to hold more urine. And this increases the bladder capacity. It doesn't interfere with the urination process. And these receptors are generally located in the bladder. The side effects for beta 3 agonists tend to be things like headache, upset stomach, as well as uh, rarely affecting blood pressure. But they rarely have effect on things like constipation or dry mouth. Now, when we get into anticholinergics, which are the mainstay and probably the most common medicine prescribed, we can see here, here's a list of medications on this table, a variety of them. And this tells you the adverse events in comparison to a placebo pill. Now, this is data from about 90 different trials compared to a placebo. And what we can see is that for each of the seven adverse event categories, you can see the events that occur per patient and the dosages as well. And you can see that when you total the score, you can see that there's almost seven adverse event categories. And the point is that what we're seeing here is that these medications have a lot of side effects that go with them. And the higher the dose and the shorter acting the drug, the higher side effect profile that you get. Now, when you talk about persistence, right? So this is the ability for patients to stay on medication. What we find is that with both anticholinergics, even with the beta 3 agonists, now this is a paper that's from about 2017. You can see that most patients aren't able to tolerate drug for even past a year. So basically, you can see there's a sharp drop off that occurs probably within the first month, month and a half. And then there's this drop off that continues to occur for these patients out to over 2 or 3 years. So the point is that like these drugs, they do have significant side effects and they are hard for patients to tolerate. And sometimes the slight benefit that patients get from it outweighs the side effects that they may get from these medications. Now, third line therapy, there's a couple of different options. There's currently onabotulinum toxin A, which is typically called Botox. How this works is that it blocks the acetylcholine receptor and basically paralyzes the muscle. This does work well in carefully selected patients who've had inadequate response or intolerant to overactive bladder therapy. Now, the guidelines for overactive bladder have changed a bit, where we used to go in a very stepwise fashion. Now it's really selecting the right treatment at the right time for the right patient. So for some patients, Botox can be an option, but side effects for things like Botox may include things like urinary tract infection, as well as the inability to urinate cause urinary retention. But that happens pretty infrequently and usually resolves after a couple of weeks. There's also peripheral tibial nerve stimulation, which basically stimulates the nerve behind the ankle, called the posterior tibial nerve. And what this does is that it basically sends a calming signal from the ankle up to the bladder and allows the bladder to hold more urine. Now, with this therapy, it is labor intensive. You're going to go to the office once a week for about 12 weeks, where there's like a tiny, almost like acupuncture-like needle placed behind the ankle. Lastly, there's a class of treatments called neuromodulation. There used to only be sacral modulation, but very recently there's something called tibial neuromodulation where there can be an implant placed in the ankle. What these do is that they stimulate the S3 nerve root, and it's a bit more invasive and higher risk than the other third line treatments, but it's a suitable option for those that want a long-term solution without the utilization of pills. So there's currently two modalities for it right now, an implant in the sacrum and an implant in the tibia as well. So certain populations we definitely want to be very cognizant of that uh, can be affected by medications. So there's age-related changes in pharmacology. What that means is that as we get older, a lot of these medications can get absorbed very differently, distributed in different areas of the bodies, and they may not metabolize or clear the same way. And so as a result, you're more apt to get side effects from these medications as we get older. The second thing is this polypharmacy. So as we're getting older, we're put on more and more medications. I would say in my practice, it's very common when I see 70-year-olds, they're on anywhere between 10 to 14 medications. And the problem is with that is the risk of adverse events increases exponentially with the addition of each additional medication. There's also the anticholinergic burden, which the cumulative use of these medications may lead to even cognitive decline over time. These adverse events also increase as we get older due to comorbidities and the way drugs are metabolized. And anticholinergics are associated with serious comorbidities such as sedation, heat intolerance, delirium, and falls. What is also a challenge is that as we get older, our hearing is not as good. So some of these patients may have a hard time hearing us when we're counseling, as well as a hard time reading small print. And we want to tailor our communication appropriately for each one of these patients. So what is anticholinergic burden? It's the cumulative effect of basically taking these multiple drugs and basically leads to higher side effects and worse outcomes for these older patients. Because older patients may forget or sometimes omit over-the-counter medications that have anticholinergic properties. Older patients are more sensitive to the anticholinergic effect, and the risks and benefits of these drugs need to really be discussed in detail with sometimes the patient and caregiver so we can prevent these effects. Um, Also, there's scoring of the burden, and there's a way to look at the variety of medications that patients are on so we can reduce this anticholinergic burden. But in the grand scheme of things, I think what's very important here is that these drugs are not benign and do have significant side effects. So when we're prescribing these drugs to the elderly, again, we want to look at pharmacokinetics and pharmacodynamics. So point is that these patients clear drug not as well as younger patients, and older patients may be at higher risk for things like dry mouth, blurred vision, constipation, as well as cognitive decline. And when we look at guidelines from both AUA and EAU, they're very clear about stating long-term anticholinergic treatment should be used with caution in elderly women, especially those who are at risk for existing cognitive dysfunction. And anticholinergic burden and associated comorbidities should be assessed in patients being considered for anticholinergic therapy for overactive bladder syndrome. So when we look at anticholinergics even closer, there's a number of reports linking anticholinergic medications to cognitive impairment. And there's an increased risk of dementia diagnosis and possibly even an increase in mortality. When we look at a recent study of about 40,000 patients between ages 65 and 99, it's been demonstrated that antidepressants, urological, anti-Parkinson medications with a higher score are linked to a higher risk of future dementia incidents with association persisting up to 20 years. So, point is that these common drugs used for overactive bladder do have potential large significant effects in the long run. So, as we had alluded to before, overactive bladder is not a condition that works in isolation. It's not, oh wow, my bladder bothers me and that's the end of it. It causes things like anger, hopelessness, frustration, worry, anxiety, embarrassment. What I'm always surprised about is when patients come in, they don't come in just saying, I urinate frequently. It's always a story of, well, my bladder's causing me such a problem. I have not been able to stay over at my grandchildren's house for, to have a sleepover because I'm afraid of ruining their sheets. Oh, I have not enjoyed going to the movies in years because I can't sit through it. Or I haven't traveled on an airplane because I'm so afraid that there's only a single bathroom. So the point is like, although we talk about overactive bladder and we're really honed in this talk, really focused in on overactive bladder and mechanism, it has a broad impact on the quality of life for our patients. And when we look at patients with overactive bladder, depression affects almost one third of them. When you look at a study of about 11,000 individuals, it was found that almost 32% of patients with overactive bladder had symptoms of depression. And this is true both for both men and women. Now, when we look at those with overactive bladder and depression, they've reported worse incontinence episodes. So the worse the overactive bladder was, the higher the depression scores as well. So when we looked at about 51 patients with overactive bladder, almost 30% had clinically defined depression, with almost 10% having moderate to severe depression. And patients with both overactive bladder and depression reported more severe incontinence, greater bother, and more impact of quality of life. And again, getting back to the idea that overactive bladder doesn't occur in a vacuum, it really has this huge effect on the overall person and the quality and their quality of life. And when we look at mental health altogether, it does also change the way patients manage their condition. So both depression and anxiety have been found to uh, negatively impact the progression and development of overactive bladder. And many patients prolong seeking treatment due to embarrassment, which can cause delay in initiation of management therapies. And poor mental health can also lead to poor compliance because what ends up happening is they're like, well, these meds aren't going to work. Nothing's going to help me. And unfortunately, these patients get more depressed and end up having more lack of self-motivation. And again, these challenges can lead to more poorer outcomes in managing these patients with overactive bladder. And what's challenging also is that for patients who, especially those that have urgency incontinence, they're doing things like reducing fluid intake, which for patients can be challenging and cause other issues. A lot of these patients have to travel with overactive bladder kits, fresh clothes, pads, and there's a lot of planning. I mean, I was surprised the number of patients that show me apps that tell you where public bathrooms are in New York City, Long Island, and you're able to map out your routes so that wherever you walk or run or any activities you do, you can find public bathrooms. A lot of patients are stuck wearing incontinence pads in case of accidents happening. And they're also limiting travel to places where there's known toileting locations. And of course, they're avoiding sexual intimacy because it can exacerbate the overactive bladder condition, or they're afraid of having an incontinence episode during sexual activity as well. So again, to summarize, how do we manage overactive bladder? Step one is to diagnose, right? You want to recognize the symptoms of urgency, frequency, nocturia. You want to apply the appropriate assessments. Um, You also want to educate and motivate patients in terms of setting realistic treatment expectations. You want patients to take ownership of their treatment. So, in other words, I want to partner with my patient and talk about, hey, this is the bladder. The bladder's got two big responsibilities. One is storage, one is emptying. And right now, we're talking about a storage problem, which causes more urgency and frequency. How do we improve that? You want to treat the condition, initiate behavioral lifestyle medication, add pharmacological therapy, for some patients, even some interventions, and also talk about the role of natural solutions as well. And then I think it's really important to have a follow-up because I try to explain to patients that, look, visit one, we're ruling out all the big bad things. Visit two, we're going to focus on what treatment we can get started on, but I need you to come back and tell me how things are so we can keep making incremental improvements in your care. So now we're going to hone in on some new options. So this is a study that we had completed, looking at the effect of daily intake of dried cranberry 500 milligrams in women with overactive bladder. But what's really unique about this trial was that this is a randomized, double-blind, placebo-controlled trial. So we looked at Flowens, which is the winner of the Nutrient Ingredient Awards in 2020. It taps into the growing consumer demand for non-pharmaceuticals, a natural solution. It's produced from sustainably grown cranberries, and it's sold with an ID pack to validate its potency, its botanical identity. I'm sorry, this is small, but this is the consort diagram. Basically showed that we had about 100 patients, 46 randomized to treatment, 52 randomized to placebo, 36 completed the treatment in the treatment arm, 41 completed in the placebo arm. And there was, from here, we did a further per protocol analysis to look at our patients. And here's our data for those who had completed the study. You can see that we had about 25 in the treatment arm, 25, 35 in the placebo arm. Mean age is about 47 in about both groups. We can see that there was the race breakdown was very similar between both cohorts. And we can see that the mean number or the number of urination episodes in both cohorts was about 12, right? So it's pretty high and pretty bothersome. And both cohorts got up around twice at night. Now, when we look at the change in the number of urinations from baseline and 24 weeks, we can see that there was an improvement by about two voids between our treatment group and our placebo group. We can see that the urgency episodes decreased almost four times as much, I mean, three times as much compared to the placebo group. And the decrease in the nighttime urinations was almost done by zero point 0.5. There was also an increase in the number of urine per voiding episode. And we can also see that when you look at quality of life parameters, these are the questionnaires that we had spoken about. And we can see that there's a dramatic improvement in the treatment arm compared to the placebo arm. Now, what we also did here is like we took our analysis and we compared it to medication, and we compared the Flowens cranberry uh, the cranberry extract, and we compared it to beta 3 agonists. We also compared it to anticholinergics. And what we found was that this medication was basically on par in terms of both the number of urination episodes per day, in addition to how much urgency patients had. So it was actually very compelling data for us. And when we talk about the Utiva product, which has the Flowens in it, it has each capsule contains about 250 milligrams of Flowens. The benefit of this formulation is supported by the clinical results we just spoke about, and it's been clinically proven to improve essentially what we call dry overactive bladder, which helps reduce the need of medication. We can see the recommended dosing for overactive bladder is about two capsules per day, it's the same as the trial. And again, when you look at drug interaction and drug safety, we can see that this has a very high safety profile. And we saw the same thing in our clinical trial as well, was that we saw very little side effects in the cohort that had done that had completed the study. So from this, we're able to conclude that the intake of dried cranberry powder improved both daily urinations, micturition, urgency episodes, the number of like how strong the desire to urinate is, and patient-reported bladder conditions, and supported its use as a safe treatment for overactive bladder. So when we look at the treatment algorithm or the treatment options for overactive bladder, we see that we've got lifestyle advices, which I think are great for all patients. Reducing not weight, but we say waist circumference, right? So if you've got a fair amount of abdominal fat, that's one place that can help reduce urgency frequency. Reducing caffeine intake within reason, right? Reducing smoking, bladder training, the use of Kegel exercises, limiting fluid intake, um, when appropriate, and getting on a regular voiding schedule. We've got pharmacotherapy, which you spoke about, anticholinergics, which have been around for a long time, but have associated risks of dry mouth, constipation, risk of dementia. We also have the use of beta-3 agonists. There's a use of neuromodulation with peripheral tibular nerve stimulation, sacral nerve modulation, and the use of Botox. And surgery, which I think is used pretty rarely of trying to create a larger bladder capacity. But what we can see here is that Flowens really does fit in very nicely, probably somewhere between lifestyle, behavioral, and pharmacotherapy. We've got very compelling data on this initial double-blind study. So I think it's a very promising agent for its utilization there. So to summarize, um, overactive bladder is a prevalent condition affecting 12 to 18% of men and women. Overactive bladder can have a negative impact on the psychological well-being, overall quality of life, and physical health of our patients. There's a variety of pharmacological, non-pharmacological treatment options that are available. And Flowens has very promising randomized controlled data for overactive bladder symptoms, especially for those that have dry overactive bladder. Thank you.
Hey, all right. Well, thank you for the talk, Dr. Chughtai. Um, there are a bunch of questions here, so we'll jump right into it. Okay. I'll probably just go in order because I think we should be able to get through these. There's an acronym here on the first question, which I'm not exactly familiar with, so I'm just going to say it. So it's DMSO bladder day surgery treatments. Are they still considered a good treatment with success for IC?
Yeah, so IC is a slightly different condition that's associated with, I mean, not slightly, it's a different condition that is um associated with pain in addition to urgency frequency. So it's really I think that's a actually a very different talk altogether, but DMSO is a reasonable option for those with IC. But again, I would work with your doctor to figure out if that's right for you.
Okay. And I'm obviously I'm assuming this is associated to overactive bladder, but is there much improvement that you know of with women taking pumpkin seed oil or saw palmetto when it comes to OAV?
Yeah. So I would say when it comes to pumpkin seed oil and saw palmetto, what really makes the supplement market kind of challenging is that there's very few supplements with clinical data behind it or randomized studies behind it. I have not seen very strong data on either of those supplements for overactive bladder. So I think over time, if we end up seeing more studies, we can definitely have a discussion about it, but I have not seen much when it comes to saw palmetto and women.
Okay. There's a variety of practitioners that attend these talks, and I noticed quite a few questions from physical or physiotherapists. So this one mentions patients have reported positive results from the MCELA chair, Kegel throne. What are your thoughts about this treatment? Are you familiar with this?
Yeah, I have heard of that chair. And I would tell you that uh again, I think we just need studies to sort of show who does best with it. Is it those with, strong pelvic floor, weak pelvic floor, more of a nerve issue, less of a nerve issue? But I think there's a variety of these treatments which can be very promising for patients with overactive bladder.
Okay, thank you. Uh, Is there, and this is a good question here, is there something that you can recommend that patients can do to avoid suffering from OEB in general?
That's an excellent question. And I think that's probably a flaw in our healthcare system, right? Our healthcare system is so problem based, right? Like you go to the doctor when you have a problem, right? We rarely ever think about what are things that we can do to prevent overactive bladder. Unfortunately, I don't think we have a clear cut exactly what causes overactive bladder. It seems like it's multifactorial, right? I do think that having a anything to reduce like have having a good BMI, having a reduced waist circumference, those are things that can help reduce risk of overall pelvic conditions. I think short of that, I mean, having a healthy diet probably does help as well. But I'm not sure if there's anything further than that that you can do to really prevent overactive bladder. And I think that's a huge area of research that we need.
Okay. This one is, does antidepressant therapy advance or improve OEB symptoms in any way from your knowledge?
Yeah, so I don't think we've got data on that in terms of like starting an antidepressant to reduce overactive bladder symptoms. But we do know that certain antidepressants do have anticholinergic properties, and sometimes they can help with things. And there are some atypical antidepressants that we will use to help with urgency and frequency.
Okay. Your the previous question was talking about, you talked about lifestyle and healthy lifestyle modifications because, I'm sure there's lots of benefits in other comorbidities as well just by doing that. So this one question talks about dietary modifications that you had mentioned during the talk. Is that just talking about caloric restrictions to promote weight loss? I guess that kind of leads back to the previous question as well. Like control what you're eating and what you're consuming.
Yeah, so I think weight loss can help, but I also don't want people to believe that, you know, there like if you have there are patients who will lose weight and they will not have improvement in overactive bladder. Now remember, a lot of stuff that we talk about is population-based studies. But we have seen across the board that like for most patients losing weight will help. So it is sometimes a caloric deficit, but there are certain foods that we do know irritate the bladder, like for example caffeine or acidic food and spicy foods. Now the thing to keep in mind even with those bladder irritants is that not all irritants are the same for every patient. Like I'll have patients that will come and tell me, look, coffee makes me really urinate. Like, okay, and then they'll try a light roast, and all of a sudden, they're like, hey, it's not so bad. Or they'll try low acid coffee, not so bad. So the point is that everyone has slightly different triggers, but I think some of them are more common to see. But sometimes you can find foods that will be less irritating for your bladder.
Uh, how do we differentiate between OAB and urge incontinence?
Yeah, great question. And so overactive bladder is defined by urgency, frequency, nocturia, which is getting up at night, and if there's urgency incontinence, right? Urgency incontinence basically is defining when there's a sudden urge to urinate and then having that leakage episode. So it's really a subset of overactive bladder.
What is your opinion regarding OSA causing nocturia? And do you recommend a sleep study for someone with nocturia?
That's a very good point, and I would say that obstructive sleep apnea is quite common, and a lot of times if patients come in and their big complaint is nocturia, in other words, getting up at night to urinate, I will recommend that they see a pulmonary doctor. And a lot of times these patients will come in with their partners, and I'll ask their partner, do they snore? And like, oh my God, I can't stay in the same bed. Right. And when I hear things like that, those are the patients I refer right to pulmonary, and we work on their sleep apnea.
Interesting. Okay. Um, Going back to the study you did with Flowens, so two questions that are similar here. One is asking, do we understand the actual mechanism of action of the cranberry powder? And is it any cranberry powder in general or Flowens?
Yeah, so whenever you do studies, you have to pick one agent. I think Flowen's actually had some preliminary studies done before where they looked at lower urinary tract symptoms in men as well. And then she had very promising data. So we had decided to use that product in women. So as far as we can tell that this is not translatable to other cranberries, just because they haven't been tested. As for the question on mechanism of action, there are things that we hypothesized, but unfortunately, we haven't done studies yet on this to figure out its exact mechanism of action.
Okay. Uh, just as a brief recap from that study, how long did it take for the Flowens product to show some effect?
We in that study we started seeing differences probably around the 4 to 6 week mark.
Okay. Uh, what do you recommend in terms of limiting daily fluids, if that is actually something you would recommend with patients with OEB?
Yeah. So I think limiting fluids, I think we have to do that. It really is very patient specific. And what I mean by that is, there are some patients, like I've got patients who've got kidney stones. If they've got kidney stones, I know they need about 2 liters of fluid a day. So we can't really limit their fluid from there. There are patients who have kidney transplants who can't go below 1.5, 2 liters as well. There's patients that I have that've got constipation, those on GLP-1s that need to be on a fair amount of fluid. So I think the fluid restriction is something you got to work with your doctor on. But I think it really depends on your hydration status, and also trying to figure out when you're getting these urgency frequency episodes. So sometimes with patients who can't limit the fluid, we work on when to time the fluid. So in other words, hey, the mornings are a little bit slow, you're closer to the bathroom. Let's get our fluid in the morning, and then the evening we kind of taper it down a bit.
Makes sense. Um, is there, given the age group of the patients that were in the study and just that you see in general, is there any place for topical estrogen as a treatment in OEB?
So when it comes to topical estrogen, I think it's fantastic for vulvovaginal atrophy. I think it's amazing for recurrent UTIs in postmenopausal women. Um, We actually did a study of looking at a combination of anticholinergics and topical estrogens. I think it works really well for um, a subset of women who have vulvovaginal atrophy, but I think women who do not have that condition or not postmen or perimenopausal, it may not be the right treatment for them. But again, a great discussion to have with your doctor to see if you have that condition.
Okay, this is just a question here. Would nicotine replacement therapy, like the sprays or lozenges, do you know if there's any side effects that contribute to OEB if someone is trying to quit smoking?
We do know smoking can cause more bladder issues. We know smoking is associated with bladder cancer as well. As for the replacements, we don't have great data on it. I mean, I do have to commend you for, trying to quit smoking. I mean, it's very, very, very difficult. But we don't have great data on how the replacements affect bladder function.
Okay. Back to another drug. We talked about antidepressants earlier. Uh, do you know which one was used that may have shown some benefit with incontinence?
So there are off-label ones that we utilize. There's some like amitriptyline, nortriptyline, imipramine. Those are off-label utilizations of drugs that can help sometimes with urgency frequency episodes as well. But again, you really want to talk to your urologist about if that's the right medication for you.
Okay. Uh, the question was related to Utiva, but it is Flowens, as you know. So, based on the trial, is there any issues for kidney or liver function when taking two a day or 500 milligrams of Flowens?
So in the population that was studied, we screened the population where they did not have underlying liver or kidney issues. It doesn't seem, I mean, I think It really depends on the severity of those issues and what other comorbidities that you have. But I think if you're going to start a medication like that, I mean, not a medication, a supplement like this, if you've got significant underlying kidney or liver disease, definitely worth running it by your primary care doctor to make sure that there isn't any comorbid any underlying issues with it.
This question is interesting. Do any agents help someone actually absorb more water into the bloodstream and reduce urine volume? For example, some dysautonomic peers, sorry about my pronunciation, were told to drink a lot of water or electrolytes, but then urine volume instead of blood plasma seems to go up. So does the type of liquid actually make a difference? And can it help keep liquid in the bloodstream?
Yes, so great question. I would say that there are medications that can help your body, help your kidney produce less urine that are used for patients who have something called nocturnal polyuria. So we can use medications such as desmopressin to help them produce less urine. But the thing is that our bodies are designed to have a very specific, what we call osmolarity, right? So in other words, the blood has to be at a very specific concentration. And that's why our bloodstream is, whenever you drink a ton of extra fluid, you produce more urine because your bloodstream can't get more dilute. That would cause, huge issues with like brain swelling, etc. So ultimately, like that's not a mechanism that we're able to utilize because of how tightly our body controls its electrolytes.
Okay. Um, General question, something like this has come up a few times here. What is the role of physical therapists or physiotherapists in your regimen and what benefits have you seen or not in terms of working with them to help patients address like pelvic floor disorders that could impact OAB?
Yeah, so I would tell you, I think pelvic floor physical therapy is absolutely fantastic. I mean, it is a huge mainstay part of our practice. A lot of the patients who have overactive bladder can also have concomitant pelvic floor dysfunction. And a lot of times, the patients with pelvic floor dysfunction can have terrible urgency and frequency. I think what the pelvic floor physical therapists are able to work with their patients, they do a fantastic job of explaining how to do degrees of bladder training, how to relax the pelvic floor musculature, how to make sure there's adequate bladder emptying. So they are a very important part of referrals that we make for our patients. And that's
And
true
that's
for both
very
men and
common.
women.
Sorry, I cut
Okay,
you
and
off.
that's true for both men and women.
When it comes to over bladder medication, what are some of the most common side effects that you have seen, and is cognition a big part of those?
Yeah, so there's two big classes of medications. There's beta 3 agonists and anticholinergics, which we discussed. And anticholinergics have been associated with dry mouth, constipation, and issues with cognition, especially with long-term exposure. Beta 3 agonists don't seem to have that issue. Beta 3 agonists seem to have more issues along the lines of occasionally urinary tract infections and cardiovascular issues.
Okay. Hey, there's been a lot of questions. Just one more question here, and I think we can wrap up this Q&A here. How many hours before bedtime do you recommend someone to stop having fluids to help decrease nocturia?
Yeah, so I usually recommend what I try to do is figure out the timing of both what time they're having dinner and what time they're having their medications and what time they're going to bed. Um, so I try to time it to be roughly around like 2.5 hours before bedtime, and then to urinate before they go to bed. But again, we want to try to get some of these details in terms of like medications and other things that they're taking, so we're not doing anything that could potentially harm them.
Okay. Sorry, one last question here around medication. What are your thoughts on Gemtesa OEB medication? Which,
Yeah, so Gemtesa, its generic name is Vibegron. It's a beta 3 agonist that's been recently approved. It does work well for the properly selected patient. We do prescribe it quite a bit as well. Again, this medication has been shown to work well in both men and women.
Okay. Hey, there were a couple other questions related to Utiva, which I'll be happy to address after. But for now, regarding the OEB talk, Dr. Chughtai, thank you very much for your time and for sharing your expertise with all of us. And we much appreciated to have you here again.
Yeah, thank you for including me, and thank you, everyone, for spending your evening with us. Really appreciate it. Have a wonderful night.
All right. Thanks, Dr. Chughtai.